This is part 8 and the last part of our module, drugs acting on the cardiovascular system, specifically drugs used to treat anemias, which is chapter 49 of our reference book. For the learning objectives, upon completion of this chapter, future SNs will be able to explain the process of erythropoiesis and its correlation with the development of different types of anemias, describe the therapeutic actions, indications, pharmacokinetics, contraindications and cautions, most common adverse reactions and important drug-to-drug interactions associated with drugs used to treat anemias, discuss the use of drugs used to treat anemias across the lifespan, compare and contrast the prototype drugs, epoetin alpha, ferrous sulfate, folic acid, and hydroxycobalamin with other agents in their class, outline the nursing considerations including important teaching points for patients receiving drugs used to treat anemias. Before we proceed into the different drugs used to treat anemia, we will first have a quick visit to anemia. Anemia is low levels of RBC resulting from alteration in erythropoiesis or process of RBC production which occurs in the myeloid tissue of the bone marrow. Erythrocytes or RBCs carry oxygen to tissues and remove carbon dioxide for delivery to the lungs. The lifespan of mature RBC is 120 days and these RBCs are lysed in the liver, spleen, or bone marrow. So this anemia is seen in renal failure, when the kidney are no longer able to produce erythropoietin. It can also occur if the body does not have enough of the building blocks necessary to form RBCs, or if a person has genetic predisposition to forming abnormal RBCs, like in the case of sickle cell anemia. So to produce healthy RBCs, bone marrow must have adequate iron, which will be used in forming hemoglobin rings to carry oxygen, minute amounts of vitamin B12 and folic acid to form strong supporting structure that survived being battered through blood vessels for 120 days, and essential amino acids and carbohydrates to complete the hemoglobin rings, cell membrane, and basic structure. So normally, an individual's diet supplies adequate amounts of all of these substances which are absorbed from the gastrointestinal tract and transported to the bone marrow. As mentioned, anemia is a state of too few RBCs or ineffective RBCs, which can be caused by a lack of erythropoietin or a lack of the components needed to produce RBCs. And this anemia can be categorized as deficiency or iron deficiency anemia, megaloblastic, which could either be folic acid or vitamin B12 deficiency, or hemolytic or sickle cell anemia. So iron deficiency anemia is lack of adequate healthy RBCs, usually treated with iron replacement therapy. Persons with this type of anemia may complain of being tired due to insufficient oxygen delivery to the tissues. And this is commonly seen in menstruating women who lose RBCs monthly, pregnant and lactating women who have increased demands for iron, rapidly growing adolescents, especially those who do not have nutritious diet, persons with GI bleeding, including individuals with slow bleeding, associated with use of non-steroidal anti-inflammatory drugs. Then, second type we have is megaloblastic anemias. So this is a condition in which the blood or the bone marrow produces unusually large, structurally abnormal immature RBCs. We call that megaloblast, characterized by very large RBCs, and these large RBCs crowded in bone marrow, and fewer RBCs are produced because of that, increasing the amount of immature cells in the circulation. So these megaloblastic anemias result from insufficient amounts of folic acid or vitamin B12 to adequately create the stromal structure needed in a healthy RBC, causing a slowing of nuclear DNA synthesis. And this effect occurs in rapidly dividing cells such as the bone marrow. So the folic acid deficiency is lack of folic acid, which is a vitamin B, in the blood. Folic helps body makes RBCs and is essential for cell division in all types of tissues. Its deficiencies are noticed first in rapidly growing cells, so like cancer tissues, GIT, and in the bone marrow. Folic acid deficiency in pregnancy will lead to neural tube defects in fetus, and that is treated with folic acid or folate administration. So folic acid is found in green leafy vegetables, milk, eggs, and liver. Okay, the vitamin B12 deficiency. This is also known as cobalamin deficiency, a condition that develops when body can't make enough healthy RBCs because of lack of vitamin B12, which is needed to make healthy RBCs, WBCs, and platelets. Failure of gastric mucus to produce vitamin B12, an intrinsic factor, will result to pernicious anemia, and this is treated with parenteral and nasal vitamin B12. The third type of anemia we have is sickle cell or hemolytic anemia, and this is characterized by a genetically inherited hemoglobin S, which gives RBCs sickle cell shape appearance. Fewer than normal RBCs are produced, which are unable to carry oxygen efficiently. Sickle-shaped RBCs can become large in tiny blood vessels where they stack up on one another and occlude vessel, leading to anoxia and infarction of tissue in that area, which is characterized by severe pain and an acute inflammatory reaction, a condition often called sickle cell crisis, wherein the patient may even have ulcers on the extremities as a result of such occlusion. Hydroxylurea has been found to be effective in decreasing acute exacerbations in this disease in adults. So, we have here erythropoiesis stimulating agents. So, for patients who are no longer able to produce enough erythropoietin in the kidneys, okay, they may benefit from treatment with this exogenous erythropoietin, which is available as drugs, epoetin alpha, the darbepoetin, and methoxypolyethylene glycolipoetin beta. So when agents are used to stimulate the bone marrow to make more RBCs, it is important to ensure that the patient has adequate levels of the components required to make RBC, including, of course, adequate iron. So you have there drugs therapy across the lifespan. So I will leave you responsible to go over on this deeper, and then with the different drugs that we have with their corresponding therapeutic actions, indications, pharmacokinetics, contraindications, adverse effects, drug-to-drug interaction, and drug-food interactions. Okay, same as well with their nursing considerations, diagnosis, and planning. So, just kindly go over them when you get a copy of your PLP. Okay, so these are. Okay, so I would just like to make mention that we use Z-track or zigzag way of injecting iron to our patients and clients. Okay, so go over also into the prototype summary. So for the different drugs used, in treating anemias. Okay, I will leave you responsible to go over them closely when you get a copy of your PLP. And that is the end for this module. Thank you for your attention.